Here we are. Here we are. Here we are. Gather round, gather round, gather round, clowns. We're rolling in here. Man, I'm sorry I'm so late. I had some serious technical difficulties that I had to deal with. So we plowed through, and so y'all know what to do. Gather round, clowns. Michael Moulton, M2 The Rock. We're coming to you live from Dallas, Texas, baby. D-Town, the 214. Yeah, that's right. So y'all know what we talk about on this show. We've had a lot of people reaching out today. They're excited to watch this show tonight because we got a good one tonight. Oh, do we have a good one tonight? We got a doctor on. Yeah, we got a doctor on tonight. I'm going to line him out. I'm going to show Doctor. I'm going to show Doctor. An addiction psychiatrist. My man, wait, this he's awesome. Dr. Lee Spencer is backstage right now. He's signing autographs. He's sharing this. Y'all know what to do. Let's get this shared out because on this show, we talk about a drug addiction. Yes, we do. Can y'all hear me okay? Everything sound good? I got a new mic. I think the mic kind of had me messed up on my connection, but y'all get this. Oh, there y'all are. I see you. Okay. So let me get this shared out to the M2 The Rock Facebook Live channel. And then let me start a watch party because I know all of y'all are starting a watch party. And then let me get this shared out to one more page because that's what we do at the beginning of this show. I see y'all jumping on here. We also talk about hurts, habits, and hangups. We also talk about resentments. We talk about anger. We talk about suicide awareness, suicide prevention. We talk about legal issues. We had Judge Bennett jump on here last night that was on the show. Do I see Hannah Fobar? I see Hannah Fobar in the comments. Hannah, she's a long time M2 rocker, and she was a guest on the show. Great, Hannah. Hannah's got some. Hello, Thomas Rawls, everybody. So, all right. So we are, now that I got this going and I want to be able to see your comments, this show is brought to you by the great Healing Springs Ranch. Healing Springs Ranch is 1 hour north of the Dallas-Fort Worth area, straight up the tollway, right off the, by Pilot Point, Aubrey, Texas. Marty Norman live in the house, my man. Everybody say hello to Marty Norman. Marty, you want to sit in on this one. We got a good one tonight. Yes, Healing Springs Ranch, 1 hour north. They specialize in trauma. And we're going to talk about trauma tonight with Dr. Lee Spencer. So we got a lot of stuff. I actually made notes for tonight's show. I actually wrote down some notes about some questions that I want to ask Dr. Lee Spencer. So we're going to talk about that. So Healing Springs Ranch and the great DFW Coin and Jewelry. That's DFW. Oh, I forgot my watch. Marty, the watch is in the other room. Oh my gosh. I usually put the watch on. I've been scrambling tonight, but DFW Coin and Jewelry. We love everything that you do for us. All right. I got to get out of the way at this time. Everybody, the way that we applaud our guests is by hitting the hearts and hitting the likes. I want y'all to do that. I want y'all to help me welcome the great Dr. Lee Spencer. Hello, Doc.
Hey there, Michael.
How you doing? Can you hear me okay?
Yeah. Can you hear me?
So this is the new norm, Doc. Welcome to COVID-19 social distancing TV. Just like this. Yes. What do you think about the new norm?
It's good to be part of it.
So, Doc, real quick, introduce yourself and tell us just a little bit of your elevator speech of who you are and what you do.
Okay. I'm Lee Spencer, and I'm a psychiatrist, an addiction psychiatrist. I have a private practice in Dallas, in Preston Center area. I guess I've been in practice about 5-6 years. I previously worked at UT Southwestern, and I'm still on faculty there. And also I worked at Presbyterian before that to help set up an outpatient addiction program. So previously worked in hospital settings and at academic settings, and now have gone out into private practice and have been there about 5 or 6 years. I treat all kinds of folks. Addiction is my primary specialty, and it's what I like doing. If you don't really have an addiction, I'm not very interested. So I used to frown upon it because I thought it made things complicated. And I have a lot of family history of addiction, and so I've got a lot of countertransference that I think I had to come to terms with. But after I did that, I've enjoyed it tremendously, and I get excited about it. So I kind of I guess what I do is try to deal with the whole person, and to especially folks that have psychiatric issues and medical issues as well as substance use issues. So I guess I kind of come in when folks have trouble getting treatment in other places. And I do see some folks with just straight up substance use, but a lot of times there's psychiatric issues and other issues, like you mentioned earlier, trauma or personality disorders or something like that. So usually folks, by the time they get to my office, have got several other things going on.
Right.
So that's kind of where I live my life. I like that.
Well, you come highly recommended, and our paths crossed in a very organic, natural way as we were trying to help somebody with this deadly disease. And I've really enjoyed talking to you on the phone in these situations. And then as I researched you and then immediately people started your name just was on blast in our camp very quickly. So I mentioned the D word, the disease. So let's kind of break this down. Addiction. Is it a disease?
Yes. I believe it's a disease in its final form. Because it behaves just like any other disease with a chronic, relapsing, remitting course that does involve elements of choice and behavior, which I think confuses some people. But the way that the addiction progresses is as any other disease progresses and becomes a disease of choice. So I very much see it as a disease, and I take the stance that it takes chronic treatment to treat a chronic disease. And therefore that's why we're able to use elements of science and elements of behavioral treatment and elements of spirituality, elements of mental approaches, cognitive behavioral therapy, all sorts of approaches that we can use for this multi-complex, multifaceted disease. Right. So I think the best model to approach it in that way, and the best model that we can use to destigmatize the treatment for addiction, is the disease model.
So if I'm asking you this, is that we have a therapist, okay, we have a counselor, and then we have a psychiatrist. Real quickly, break those three down. What is the difference between those three? Because if you just go to it, hey, the psychiatrist can prescribe medicine, okay? But there's a definite difference between the three?
Right. Psychiatrist, yeah. In short, the psychiatrist is an MD, a medical doctor, and goes to 4 years of medical school. And psychiatry is a 4-year residency program. And then if you would do any addiction or any other subspecialty, it's usually another fellowship on top of the 4 years of residency. So that, in short, is a psychiatrist is an MD. A psychologist is a PhD, meaning they've gotten a doctor of philosophy and done a dissertation. And then we have therapists, and therapists can have, almost any level of training, but typically master's level or above. They've done a master's in social work or a master's in, an LPC, licensed practicing counselor. There's multiple ways to be a counselor, but usually that is master's level or above. And then what's the other one you said?
Therapist.
Or counselor.
Therapist.
Oh, yeah. Well,
Counselor,
therapist is, I guess therapist would be kind of the umbrella term. And then anything under that, anything that's master's level or low, I guess we would call a counselor. And, licensed chemical dependency counselors, kind of general counselors, et cetera. Anyone below that level. Okay. I think that's kind of how we break it down. But it's confusing. It's a confusing soup of terminology we've kind of made up for ourselves.
So as an addict like myself, and let's say that I'm trying to get clean and sober, and it's like, listen, why should I go to treatment? Why should I go to rehab? Why should I go to a therapist or a counselor? I might as well just go to a doctor. I'm just going to go to Dr. Spencer because he can fix me. I can afford it. I'm going to go see Dr. Spencer. I don't want them meetings and all that stuff. what is that theory? How does that play out?
Yeah, it's a good question. I mean, a lot of people seek medical treatment as their sort of primary means. They go to their primary care doctor, right? Or
Mm-hmm.
they go to a nurse practitioner, or whoever they usually is their touch point for chest pain or shortness of breath, or whoever they go see for medical illnesses. In fact, if you look at the statistics, I mean, the gross majority, probably 80% of folks that are trying to get sober, that's their initial point of contact. At least we think. It's not very well measured, but folks believe that it's the easiest way to get started, and oftentimes it's the primary care doctor that sees them first in that initial setting. But the problem with just treating it as you would, asthma or diabetes, with going to see just the medical doctor for it, is that it's much more complex phenomenology and form of addiction, because it involves issues of social contacts, it involves issues of personality, it involves issues of childhood trauma or adult trauma, it involves issues of relationships, it involves issues of spirituality. I mean, it is a multi-complex problem. So going to see a psychiatrist and getting on Prozac is not going to be a fix. People are often looking for a fix, and people often ask me, what do I do if I'm a psychiatrist? What role am I playing? And oftentimes what I'll tell them is I'm kind of a general or a quarterback maybe, and I help kind of point people into different aspects of treatment, kind of like almost a pie chart approach, help them figure out what therapist might be the best fit for them, what doctor is a good fit for them, what treatment program is good, what's the role of their sponsor, what's the role of AA, what's the role of a treatment program, et cetera. So so it's a multifaceted approach, and and a physician, I guess, I'm making a long-winded answer of your question, but to a physician, the other problem is that they oftentimes don't have a lot of time with patients, and this takes a lot of time to break down and to understand and uncover what's actually happening, what's going on.
Right.
And physicians, may have 5 or 10 minutes to spend with people. And the reality of psychiatry these days is that most psychiatrists see patients for 15 or 20 minutes. And I can barely get a depression inventory in 20 minutes.
Right.
So it's that's I think where the medical model fails us a little bit, is that just a medical treatment itself, quote unquote, is not all that's needed.
I'm seeing we got a lot of people watching, and I'm actually seeing some comments in here, and I see there's somebody has asked a question that's kind of stirred up a hornet's nest here, and I think it's right. Good. I think you and I can handle this. I can assure everyone here, a lot of people who are there are people in recovery. There are people that are in recovery on also loved ones that have loved ones who have died in recovery that will take shots at the medical field as licensed drug dealers. Okay. And that's what we said. How does that I don't understand that. I mean, I could see maybe an orthopedic surgeon being a licensed drug dealer to write script for opioids and all that. I don't see that in the psychiatry field, or am I wrong? It's something that's out there that is a problem.
I'm assuming you're talking about prescription substances that people are misusing.
I'm assuming too. I kind of want to bring it out here because the guy brought the question and everybody's looking at it. Is they're just assuming, they don't know you yet. We just started, so the shots are fired. That there's a licensed drug dealer on the air, and let's clean it up. That because we have talked about that, and we're going to get into it later on the show about medically assisted treatment programs. About that. But what is your take on that when doctors? Because there are a lot of great doctors out there, Dr. Lee Spencer being one of them. Because what I love about you, Doc, is that you do address the body, mind, and spirit. Okay. Yeah. And you talked about that earlier. We talked about that on the phone. But what about the people who obviously have a resentment towards doctors?
Yeah, that's understandable. I mean, there are certainly a few doctors who have probably, screwed it up for much of the medical field in terms of overprescribing. Overprescribing opiates, overprescribing benzodiazepines, overprescribing Adderall or amphetamines, which is, a big problem these days too. And some of that is probably unscrupulous doctors, like with any field. I mean,
Right.
there's people out there that are just interested in money and they want to see as many people as they can as make as much money as possible. And, that's obviously is an ethical problem, and hopefully it's very few of them. But there are people out there that are poisoning the well with that stuff. But more generally, I think a problem is an artifact of what we were talking about earlier, with not with a time issue and a patient relationship issue. If you've got a doctor that's overstretched and is seeing 40 patients a day, let's say for 15 minutes apiece, and you've got a patient that comes in with a history of addiction and doesn't disclose a history of addiction, or maybe does disclose it, and has got 7 other problems, including, pain somewhere, depression, anxiety, sleep issues, headaches, chronic migraines, stomach pains, GI issues. The amount of time that he or she has now to ask about history of addiction, family history, serious mental illness, etc., is very limited, because, they got 15 minutes with a patient by the time they do a physical exam. I mean, so oftentimes my perspective is that people get prescribed pills because the doctor wants to relieve suffering in a way that he thinks is going, or he or she thinks is going to help the problem acutely. But what ends up happening is that substance gets misused, or the person begins to get addicted to it. And then the follow-up is very few and far between, and not close enough. And that pretty soon that person has developed a physical dependence, and then a mental dependence, and then addiction. And so in that way, I guess I can empathize with the caller, or the person who messaged in about doctors being drug dealers. I think part of the problem is a systemic issue with healthcare in general, and I can sense that with a lot of doctors, because they don't have. I mean, I have 45 minutes to an hour to spend with patients, and mostly what we're doing is breaking stuff down. Most doctors don't operate that way. That's not what they're set up for. And I think our field needs some overhaul. I think the medical treatment field needs a lot of help in that regard, because we've probably done a disservice by overprescribing. I mean, that's what you saw in the early 2000s happen, when the pendulum swung toward chronic pain or acute pain as a fifth vital sign. And anything there, and you see the medical community come out with this report that no one should be in pain. Pain is not something that should be tolerated. And when you see that, you see the overprescription of opioids quickly follow that, along with the advertising of big pharma and the heavy marketing and the lobbying, et cetera. And physicians are, fall victim to that, and thinking that pain needs to be relieved at all costs, and we'll do whatever it takes, and we have the medications to wage against that pain, and so therefore we'll prescribe it. And unfortunately, what you get is a lot of people that end up very addicted, and people die.
Right.
And so I think it's a systemic issue in medical treatment. Yeah.
So let me ask. So, are you yourself in recovery? Are you an addict, or do you have chemical dependency issues? And so, a question.
No.
Yeah. So
I'm addicted. I know I'm addicted to golf and fishing, but I have a massive family history of addiction, and I have seen it firsthand for many, many years.
Wow.
And so I'm kind of naturally drawn. I'm naturally drawn to it. Because it runs so deep in my family, and I think that's probably why I feel a connection with it, because it hits home.
Right. What is when you meet with people that are struggling with, just for this show, let's talk about alcohol and drugs, okay? And there's so many things that we can talk about, and we'll have to do some more shows. But for this case, alcohol and drugs, okay? Narcotics and alcohol. What is the common denominator that you see with those clients? What is the common denominator that when you sit back and you're processing, going, and the real root, Doc? I mean, like, wow, this is the common denominator that I'm seeing in every single one of them. What are you seeing?
I guess the common denominator would be that there's no single denominator. I see a lot of complexity. And so I try to individualize the treatment to everyone, or at least my formulation of what's going on. And I try not to over-interpret in a single manner what I think is happening, whether I think there's a trauma, or I think, I just saw 10 patients with a major depressive disorder, so I don't want to impose that on you if I don't pick up on it. So I try to take kind of a bottom up approach and say, let's start from scratch and let's break this down and see what's actually happening. I would say, after having said that it's multifaceted and complex, et cetera, I think whatever the underlying cause is, whether it's a childhood issue or whether it's an issue of significant psychiatric disorder, or whether it's a strong genetic load to be an addict, I think one of the major factors I see is an inability to tolerate stress and discomfort, and seeking the ability to cope or escape with that through the use of substances. At least that's what I see in the final common pathway after the addiction has really progressed. You know what I mean? And what starts an addiction is obviously not what sustains an addiction, but by the time they get to my office, they're in a sustained addiction. And oftentimes what I see in that sustained addiction is someone who's having real difficulty coping with the distress of life without a substance, because that substance has become the norm with which they cope. And that is, I would have to say, by and large, the most common denominator. That and a strong family history.
Yeah, I agree with that. So, so what I heard you say, fear, processing. I tell everybody my personal story is at the end of the day, I didn't have any tools on how to process fear. When I started getting in fear and getting in future tripping and the stories became really real and alive, I did not know how to process it. And I talk about addiction. I'm living either in the future or I'm living in the past. And in order to get to the now, when I drank alcohol, it gave me that feeling of, right. And so it just shut down. The future and the past shut down. And in order to stay in the now, I kept doing more and more and more. Right. And then I had consequences in the now. So to make that go away, I do more and more and more. So that's where the cycle and it starts getting very. And my personal story, Doc, is that I always took the easier, softer way. I was going to docs and I was working them. I was that guy that was working on trying to get Adderall, trying to get these fixed. And I look back on it, on my story I was constitutionally incapable of being honest. Right. I didn't know how to get honest with you, Doc. I didn't know how to get honest with you and say, man, I'm about to crawl out of my skin and I can't process right now. And it actually ended up being trauma issues, PTSD, and stuff like that, until I finally started addressing those things. I started getting the relief, and all of our stories are different. And of course, my story was crazy, it took jails, institutions and near death, to get sobriety. Long-term recovery. What are you prescribing for long-term recovery? So for a client that you're working with, coming to see Dr. Spencer and checking in and where we're at today, what are you prescribing for clients to stay sober 24 hours a day?
Yeah. So we're talking about in a kind of a long-term maintenance phase. They've got to have a support system, whether that's organized around their family being supportive, or whether that's a support system through an institution like AA. I want to see that they are connected, because as we've talked about probably before, connection is the opposite of addiction. Really, one has to be connected in a world and not isolated and alone in order to cope. I mean, these institutions have been around this long for a reason, because they are helpful, being involved with family, being involved with some sort of spiritual institution, if possible, being involved in a recovery network, having people who are guiding you along, having accountability partners that are there, sponsor figures. That's what I want to see. I want to see that, and I want to see mentally that they are staying in touch with the people they need to. If they need to be in therapy, I want to make sure that they're following up with therapy. If they've got medical issues, I want to make sure they're following up with their medical doctors for those issues. I want to make sure that the body, like you said earlier, the body, mind, and spirit, that those layers are being addressed, and those and that they are continuing that on a routine, structured basis. Like, that's usually what I'm talking to patients about. And if there's an acute issue that comes along through that maintenance phase, we'll deal with that. But in general, if you've got that scaffold of recovery, then people can do so well. That's part of why I love this is people can do so well. New evidence of that.
So is it possible that I can just come see Dr. Spencer once a month and just stay sober? Or if I
wish I'd be a rich man.
Yeah. So y'all heard that. I wanted everybody to hear that that's watching this, that Dr. Spencer's saying that, listen, it's just not him. Let's talk about the body, the mind, and the spirit. And let's have fun with this. You ready? I learned this. I will never forget when I learned this, Doc, in a state institution that was sponsored by the Texas Department of Corrections that I was at. And they had a counselor.
Institution. It's been there, yeah.
Tested,
right?
In 2002, I was at Betty Ford. In 2017, walked out of the penitentiary, right? And so, but my story is, I'll never forget when I listened to a doctor talk to the inmates about the phases of recovery. And it really made sense to me on the body, the different phases of recovery, the detox phase. Okay. Walk us through the detox phase and the first 3 phases of recovery that we can expect. Because we have a lot of people in very early sobriety that tune into the show.
Sure. Yeah. The detox phase is often one of the most difficult phases because that's where, because of the symptoms that one's experiencing in his or her body, it's easy to relapse because it's a very uncomfortable phase, So if I've got somebody that's withdrawing from alcohol, which is a sedative, if you think about it, the detox phase is the opposite of sedation, which is hypervigilance, awareness, hyperarousal, increased blood pressure, increased heart rate, proneness to seizures, proneness to heightened anxiety, inability to sleep, all of that stuff. So it's a miserable state to go through when you're coming off a sedative. Same with benzodiazepines. It's a very similar picture, but often more protracted, more prolonged, more complicated, etc. But that's kind of the sedative withdrawal phase. And with opioids, with heroin or oxycodone, hydrocodone, whatever, it's a period of anxiety, physical restlessness, and needing to sort of feeling like you have to move all the time, shake your legs, cramps, nausea, diarrhea, chills, vomiting, that goes on for 3 or 4 days typically. The more acute, the more life-threatening withdrawal syndromes belong to alcohol and benzodiazepines, because those are actually the ones that can be, have a high mortality rate if they're not treated, especially if accompanied by seizures. And sometimes people can even hallucinate and start to, see things that aren't there. And then eventually their blood pressure spikes up and down, and it's a dangerous situation. So that's the one that I try to be really careful with.
Right.
Amphetamine withdrawal tends to consist of basically depression and sleeping, and just a sort of an unstimulated state, a sedated state. So typically it's the opposite of the desired effect of the drug is the withdrawal state.
And what is the brain doing in the detox phase? I've been taught that it's rapidly rebuilding dopamine. Is that correct?
Partially, yeah, it's doing that, but that takes a while to rebuild. If you go back, Michael, to your cellular biology and you think about what's happening when you're restructuring a brain or an organ, your brain is the slowest probably of any organ to regenerate. But you got to rebuild proteins, and you got to move proteins around because that's what builds up the structures of your brain, like with receptors and neurochemicals and stuff. And to rebuild a protein, you got to go into you got to travel into the cell. You got to go into the nucleus. You got to find the DNA, unwind the DNA, turn it into mRNA, turn the RNA to the ribosome, turn it into a protein, ship that back up to the cell. That takes a month. So at least, and so the brain is going through these regenerative processes for 1 to 6, some would even say 12 months. When you're talking about replenishing dopamine and stuff, that takes a long time. What's happening acutely in the detox phase in the brain is a recovery from the dynamic that's been happening. And so if you've been drinking alcohol, let's say, every day for 6 years, and you all of a sudden stop. Your brain gets used to a certain level of GABA, which is an inhibitory neurochemical. Okay, let's oversimplify this, and let's say you have one excitatory and one inhibitory chemical. Your inhibitory chemical would be GABA. Your excitatory chemical would be glutamate. Okay, glutamate is your accelerator. GABA is your brake. So let's say you've been abusing alcohol or misusing alcohol or whatever for 6 years. Your brain has gotten used to a certain amount of GABA in the system, and it's gotten used to a certain amount of glutamate in the system, and it's gotten used to it. Every day it's depending on this. And so when you drink, your GABA goes up a little bit and your glutamate goes down a little bit. And then when you wake up, it kind of reestablishes its set point. When you stop drinking all of a sudden and take that away, your brain, let's say your GABA goes way up here, and it says, well, it actually says, where is my GABA? Where is it? I'm so used to having it. And so your glutamate goes way up here. And so what you actually get is a hyper excitable state. Your brain is saying, I need GABA to slow me down. And so that is what creates this increased blood pressure, increased anxiety, increased pulse rate, et cetera, because that glutamate is spiked so high and the GABA really has not normalized yet. And so that takes 4 to 7 days really to kind of normalize there.
And here's where it gets complicated. You talked about complicated. This is really good. So this is Dr. Lee Spencer here on Into the Rock. If you're just joining us, a psychiatrist here in Dallas, Texas, very well known. He got a great following. Into the Rock highly endorses him. We've talked a lot on the phone prior to the show. A lot of people that follow Into the Rock, and but you and I have talked. I'm a God guy. I am a God guy, and I have that belief that I had this spiritual stronghold of addiction. I get that, okay? I also get the science side of it, just what you just described right there, right? Because that makes sense to me. Here's where it's risky, what you just described there. As this is going on, Doc, this is uncomfortable. This is real uncomfortable, and it's new because I've been drinking for 6 years every single day, and I'm trying to get sober, and this is creating anxiety. And my solution to anxiety was alcohol, right? Yeah. That's what I thought it was. So I had to do more and more to make the anxiety go away. Doc, explain to me that in this point that you're talking about, why is connection so powerful right there? Because I was a part of that. I have seen people that come into support group rooms that are 2 and 3 days sober, and and I do it in treatment, working at Healing Springs Ranch. I literally watch flowers bloom, in 10 and 15 days as a result of connection. Yeah. Why is that so powerful?
Well, like you said, that's the natural tendency, is to restore that balance with whatever means necessary, right. And what alcohol you've known for the last 6 years is tried and true. It works every time. It restores your GABA, right? It immediately calms it down. The problem is that over time, as you see, you get back to that imbalance where you have less and less ability to tolerate stress, because then alcohol or Xanax or whatever becomes your only way of dealing with that distress, is by restoring GABA immediately.
Right.
What you asked about with connection, what that ability to build relationships with other people, what that does is it bypasses this system and allows you to allow those things to naturalize normally on their own, and you build connections with other people to keep you outside of that paradigm. There's so much more to being able to tolerate life and enjoy life and process life and learn about yourself and develop a deeper relationship with God or your higher power. And those people allow you to do that. They take you outside of yourself. They give you some other perspective. They help you realize that this is just temporary and that you're going to be okay, and that drinking again is not going to be a solution to the problem. And so they remind you that there's so much more, to life than GABA and glutamate, and that stuff will normalize over time if you can find something and find connections with people to get you through it, and I think that's what really good treatment programs do, is they get you connected. They get you realizing that this is not all there is,
right.
that there's so much more to life. So I think that's where it helps.
No, I think it's cool how you described that. Okay. And we had somebody, that's medication medication doesn't make that happen. That's a whole other conversation. It's cool to watch. Right. And so let me ask you this, based on my story. I was a chronic relapser. I was obviously 27 mugshots, lost everything. I didn't lose everything. I gave everything away. Right. That's recovery today for me. And when I speak, Doc, in front of everybody, the first thing that I say is I don't want anybody to get confused. I drank alcohol and I did drugs for the effect. And that's true recovery saying that. Okay. I have a disease. I have a choice. I could treat it like a disease and live happy, joyous, and free, or not treat it like a disease and die. Okay. That's the way I'm working it. Okay. The mental obsession, Doc, has been removed. All the other times when I would get released from jail or things would get going good, I'd start craving alcohol. When things are bad, craving alcohol. Why this time? The mental obsession is gone. My dad just died 4 days ago, I think. Okay. It was 4 days ago. I just got the news that my dad passed away. I actually almost, the day it happened, I was going to start rescheduling the program and start moving you back. I held on to this show. Okay. And I've been talking on the phone with other people that need help. And they're helping me. They don't get that yet, but they're helping me because it's keeping me out of self. All right. But the thought of drinking and drugging never, ever entered my mind. Okay. Why is that? What happened?
That's a good question. You want me to approach that from a scientific standpoint?
I want you to approach it any way you want to. I have an answer to it. You know what I mean? But I think this is really good. This is Bill Wilson, Dr. Silkworth talking, okay? And the doctor's opinion. The story is Bill Wilson had a spiritual awakening, okay? He came to Dr. Silkworth and he said, listen, do you believe what happened to me? He goes, well, I'm a scientist, but I do believe something happened. And what's amazing is you're staying sober. So instead of telling everybody about Jesus, why don't you turn your pitch and go and tell everybody about the disease? Okay. And let's slowly get into this. That's why step 3 is where it's at. Right. Yeah. But I want to know from the mental obsession, it's gone. It's gone.
Yeah. That's beautiful. I mean, when from a scientific standpoint, we're still very limited in understanding disease, especially diseases of addiction in the brain, because the brain is very hard to study. But there are 3 pathways that have been identified that I think are helpful in understanding something like this. I don't know if on your show you've talked much about kind of the reptilian brain, or the sort of more primal brain that we have, and the more cortex. I don't know if that's been mentioned or not.
No, and so they will have you on to talk about that. First of all, I can't spell reptilian. So that's way too big a word for me, but
I'm sorry. Yeah. No, primitive. Let's call it primitive brain. Okay. Let's talk about like brain of survival. Right. Okay. And that is, I need to eat, I need to sleep, and I need to get away from the bear if the bear is coming to threaten me or my family or my steak that's cooking over the fire. And my brain that's primal in that way, your brain, same way, is built reflexively to protect us, and it'll do whatever it takes to protect us. It's easy. It works. It's fast. It's reflexive. If I need to run away from the bear, I'm going to run away from the bear. If I need to attack it, I'm going to attack it. And that brain works on dopamine is a big part of that, like you mentioned earlier. And the pathways that are involved in addiction oftentimes involve those same pathways because they're fast, and you can think of it as an older software, or actually a faster software system. Mm-hmm. The cortex, which is where we do all our planning, thinking through things. Is this a good idea? Not a good idea? Should I not use? Should I be sober? Have I called my sponsor, etc.? That's more of the cortex. That's a newer processing center. It's a slower, it's a more deliberate. It's not the one that's engaged when the bear walks up and wants to eat your food, Mm-hmm. And addiction operates on the more primal brain in that faster, older network. And when you are previously, when you were in your addiction, that network was much more active. It had not learned other networks or mechanisms of dealing with distress or thinking through things because it was the default network. That was the fastest way to get you out of distress. And so we call that the mesolimbic or mesocortical system, because what those do is from the middle part of your brain, which is the older part of your brain, to the higher part of your brain, it has to develop. And some would say even that addiction has kind of a developmental aspect because this connection seems to be disordered in addiction in folks who develop addictions. And so what happened with you when you were compulsively thinking about the substance as your only way out and dealing with distress, that was that old part of your brain that was working. And so when you went into recovery and developed all these years of recovery and built this network and turn to your higher power, you learn to build new networks to think through problems in more rational, problem-focused directions, and you don't use those old networks anymore. They're still there, but you've covered them up. You've developed new pathways that you don't need those old roads, those old highways anymore. Does that make sense? So
no, that makes perfect sense, because what makes sense to there is that if I were to, as soon as I get off this show, choose to go drink again, okay, like a normal person, I can't do that because then that part is regenerated or re-stimulated, reactivated, and then it shifts back over. And that's why when I drink again, I'm back drinking to the same amount I was immediately. It's not like I'm just drinking one, and it's interesting, Doc, because the times that I relapsed, I go, oh, tonight I just had 3 beers. I'm good. But I remember the mental obsession. I thought about drinking all night. Right. And then the next day it was over. It was just, I couldn't stop. And that makes sense to me. You taught me something there. I can relate to that. Here's something else to talk about that a lot of people who are watching this in recovery, and then we're going to end because I want to talk about the family disease, the other side. I know we have a lot of people watching right now that on the show, like, how can I get my son, daughter, to watch this and get them help? And we're going to address that real quick. I was walking the other day. I've been doing a lot of walking lately because
join the club. Yeah, it's about all there is to do, right?
You're right, to get out and walk, and which is part of recovery, right? To get moving. Yep. I was walking, and Doc, everything was fine. Okay. And I'm just walking and I look up and it says 42-degree or 39-degree beer. That's a sign said it. Immediately my brain starts, I immediately started craving beer for just a second, and it freaked me out. I was like, where did this come from? Where did this come? What is that?
That is back to that pathway.
Yeah.
So if we go back to that pathway and you look at what another pathway that's called the nigrostriatal pathway, it is a way that our brains learn to associate different signs, stimuli, visions, cues, whatever you want to call them. We learn to associate those things with the things that give us the reward, the dopamine response, right? And when you see that billboard and you see a Miller Lite can or whatever it is, I don't know what it was, but whatever it is, if it touches that spot, it gives you a little mini dopamine spike in that pathway. And that's what your brain says. Oh, that's the old craving. I remember that. Like you said, that never really goes away. That pathway is still there. So when you get a craving, and you will, it doesn't mean that you're obsessing about it necessarily. You just have a craving. It's a little dopamine spike. If you then drink, your dopamine goes way up here, and then you're in trouble because then your brain is going to seek that dopamine spike again and again and again. But a craving is just a mini dopamine spike in that same system.
Oh, yeah.
And it learns how to associate cues. I mean, your brain is an incredible organ at remembering associations like that.
Drinking,
and a lot of times people aren't aware of it. They're not aware of what triggered them, but there was something there. Yeah.
They're going to love this question. Drinking and using dreams in recovery.
Ooh, yeah, I love that one.
What is that?
That's a craving. It's a mini dopamine spike. And, people come in all the time and they're freaked out and they're panicked because they're a month sober and they're like, God, I'm doing great. I don't have any cravings, nothing, no problems. But I did have a drinking dream. And I love to talk about the drinking dreams because, the interesting thing about drinking dreams I find is, let's say 75% of them, they come away with this kind of negative feeling. There's a guilt.
That's right.
Because they in the dream they had already drunk, and now they're facing the consequences of that, or they're now they got to deal with their husband or their their granddad or whatever, right? And everybody's is embarrassed and mad at them, etc. And so I actually find those dreams useful because you can process the fact that there's all these negative consequences. Let's use that. Let's hang on to that, because in your dream, you weren't drinking and enjoying. You appreciated the negative consequences of drinking. So what it is your brain, playing out that dopamine spike in a craving system, and it's useful because it's grist for the mill for you to be able to work through some of your recovery processes by processing through your dreams. So I think they're nice. I like dreams.
Well, and I agree with you, because when I have people call me and say that they we have a lot of people commenting on this. This is great. We struck something. When people say that they have using dreams or drinking dreams, and they call me and I say, hey, what a great time to feel gratitude. Being grateful that you're sober today, right? And that
Amen.
You do it.
Yeah.
I'm making some notes, and everybody here on Into the Rock, I'm right here live on the show going to nominate Dr. Lee Spencer as the official addiction psychiatrist of the show that we can bring. This is great because we need to talk about trauma. We need to talk about not tonight, but trauma, relapse. We need to talk about process addiction. We need to talk about relapse behaviors. We need to talk about sex addiction, gambling, all these things that we can talk about.
Some good stuff.
Good stuff. Relapse. Hey, I relapse. What do I do? Do I just go sit up in a hotel for 12 days? I'm in a hotel. I'm stuck. I'm full of so much shame. I'm tired of going to treatments. I'm tired of doing the same thing over and over. I'm just going to hear the same thing over and over. There's so many things that we can talk about. But here's what I want to end with, Doc. This is a family disease. And we have a lot of people on this show that watch trying to be educated about their loved ones who are in active addiction. Okay. Mm-hmm. And this is something, let's just end with this. What do you prescribe for the loved one let's say their loved one is in day 3 of treatment? They're in treatment, hey, doc, get them in treatment, fix them, bring them back to me. I'm going to go back to my life. Uh-oh. So what do you prescribe for the family and the loved ones?
Well, that's a good situation if they've gotten them into treatment,
right?
Because then this is an opportunity for them to really look at themselves and say, what's happening here? Have I contributed in some way? How did this whole thing happen? Because like you said, it's not limited to an individual. I mean, this is a dynamic that involves families and involves whole ecosystems of people. And an opportunity there is to say, I encourage people to look at themselves when their loved one goes to treatment, because they'll find that there's something about themselves that needs help, that they need to be honest with what's going on. And them being in treatment is just the start of the conversation.
Right.
It's the opportunity to say, what is happening here, and how did this develop? Have I enabled this? Have I been complicit in this somehow? Have I ignored this? Have I been in denial? Like, how can I start to address this problem? How am I going to deal with it when it comes back? What processes are we going to use in the future to have conversations? How are we going to learn to communicate better? How are we going to learn to talk about illness? What is addiction? What does it mean? How am I not going to be afraid of that? So, when somebody gets into treatment like that, it is an opportunity to open things up. And so I always encourage them to be part of the family process and treatment. If there's a family weekend or a family day or a family call or, a family week or whatever, program is offering, I always encourage people to do that, and then also to look at support systems for themselves. Like Al-Anon, to get into a program and start working their own program, so that they learn not that they can't control this issue. That they have to focus on what they can control, and accept that the person's got to come to their own understanding of the addiction and their own awareness and acceptance of it themselves. So that's the conversation that I have every single day with families.
Right.
I mean, I think sometimes that's where, my bread and butter is families dealing with loved ones who are going through this, and just educating them about it, teaching them about the process, teaching them about the issues of control, talking to them about taking the time to look at themselves and be willing to, uncover some stuff, and deal with some difficult issues, and that it's not just an isolated thing, So it's a disease that involves the whole family, and the recovery is going to involve the whole family.
There you go. Yeah, this disease will take us out in big numbers. Recovery will save us in big numbers as well. Closing thoughts, Dr. Spencer. 12-step recovery. Give us your thoughts and feedback on 12-step recovery.
12 steps, I think, is a useful way to live your life.
Yeah.
And I encourage people to do it, whether they're addicts or not. I shudder to find another system, another program where people can be more honest and be more aware of the stuff that they're dealing with. I mean, how often do you meet, let's say church-going folks? How often are they working a program? How often are they looking at their own resentments? And making amends. I mean, how often are people out there walking around don't even know what a resentment is or what it feels like?
Right.
How often are people dealing with serenity prayer and issues of control? And so, I just find a 12-step program to be, incredibly useful for people. It's widely available. You can find an AA meeting in 67 places in Dallas. You can jump onto a meeting anytime, anywhere, and any place. And for that reason, people that are in 12 steps, I find do better than people that aren't in 12 steps. I mean, that's just kind of basic statistics for me. And so I try in my practice to divorce myself from any ideologic belief in a particular methodology. I don't try to impose my own beliefs on anyone. I don't try to, tell them they have to read the Bible every day. I don't, none of that. But I do tell them that people that are in 12 steps, any kind of support group like that has more success than someone who's not. And so I just try to keep it, down to the kind of brass tacks with them. And I just find that people have that level of support, just they come to more insight faster. Wow. It's it makes the therapy more enhanced. It makes the recovery easier, and it makes the prognosis better. So
good stuff. Dr. Lee Spencer, what a great show. Great show.
Awesome.
I'm so sorry for being about 4 minutes late. I was trying this new mic out and I got, never mind. But anyways, I am right now live. I want to invite you back on the show. And we definitely want to invite you out to Healing Springs Ranch. We want you to tour. Y'all speak the same language, and you need to come check it out and see what we're doing out there. This has just been so wonderful from the medical side of what you bring to this show. We need someone like you so bad on the show. We've got so many things. I mean, we got things from, drugs and alcohol. We got pornography. We've got gaming. Gaming is the gateway. This is an opinion, a gateway to addiction. You know what I mean? Yeah, I spoke at the schools last year right behind your building, and spoke to those kids. And I said, listen, I want y'all to understand what addiction sounds like. And I had everybody, if you love to play video games, raise your hand, and the whole school raised their hand. And if you were to have video games taken away from you for the rest of the year, would you be angry? And they all said yes. Okay.
Yeah.
maybe that's a visible thing to try to fix invisible problems. So we got a lot to cover on this show with you, Doc. And real quick, and in the comments, Doc, we're going to put all your information, your website, but where can people get in contact with you that want to work with you?
Yeah, I have a website. It's leespencermd.com. That's probably the fastest way to get there.
Perfect.
And then my phone number's on there and stuff. So, and
so
email.
We'll put you in the comments, and Doc, I'm gonna put you backstage. Don't go anywhere because I want to say goodbye to you, and I want to have some closing thoughts real quick. Everybody, hit the hearts. Thank you, Dr. Lee Spencer, so much for being on the show, and we will definitely have him back. Wow, that was good. That's brain overload right there by the great Dr. Spencer, and we will definitely have him on. There's so many things I wanted to talk to him about. We addressed we're going to talk about next time medically assisted treatment. Early in the show, shots were fired. Someone jumped out there and made an assumption, and I loved it. And I hope they stayed on because, listen, everybody's welcome to this show, and Dr. Spencer really addressed it well. Not every doctor, their solution is writing prescriptions. Dr. Spencer is a professional. He takes time with his clients, takes time with his patients, creates an intimate relationship to work through is what I heard. And I know that's what he does. He's got a great following here to Dallas. And let me tell you this, his following here in Dallas are in the comments in this show. And you know what the common denominator of his following? They all have long-term sobriety, and they're all helping others. All right, tomorrow night, we'll be back. Tomorrow night, I'll be doing the 12 steps in 1 hour. So if y'all want to watch and go through the 12 steps in 1 hour, I do it once a month, and that's tomorrow night on Wednesday. No Wiggin Wednesday, tomorrow night on M2 The Rock. Remember, guys and girls, I got 3 words. I got 8 letters. I got one meaning. It's got one meaning, and that is I love you. Good night, everyone.